All right. So, good evening, everyone. I'm Dr. Kshitija Patil, a DM medical geneticist from AIMS New Delhi, currently working as a consultant clinical geneticist at Apollo Hospitals, Navi, Mumbai. On behalf of Organization of Rare Diseases India, I extend a warm welcome to everyone joining us today for another webinar of the Rare Info Series. ORDI continues to play a vital role in advancing awareness about rare disorders by fostering a platform that brings together clinicians, patients, caregivers, and advocates. These interactions are crucial in deepening our understanding of rare conditions and strengthening the long-term care and support. I would like to inform you that today's webinar is being recorded and will be available for later viewing on ORDI's YouTube channel. Today's topic is Wilson disease, a rare inherited disorder of copper metabolism with a wide and often challenging spectrum of clinical presentation. The disease may present with hepatic, neurological, psychiatric, or mixed manifestations, often leading to diagnostic delays. And early recognition and timely management are crucial for the treatment and outcome and quality of life. To speak on this important subject, we are honored to have with us Dr. Aabha Nagral. Dr. Nagral is the Director of Department of Gastroenterology at Jaslok Hospitals and Research Center, Mumbai, and brings with her over 32 years of experience in hepatology. She is widely regarded as one of the earliest clinicians in India to focus on hepatology and has played a pioneering role in the field. She has been instrumental in setting up liver transplant programs at Apollo and Jaslok hospitals and was involved in the first successful pediatric liver transplant in Western India. Dr. Nagral trained in gastroenterology at KEM Hospital in Mumbai and also pursued advanced training in liver disease and liver transplant at the Royal Free Hospital and King's College Hospital, London, and the Mayo Clinic, USA. She currently serves as the chairperson of liver transplant at ZTCC Mumbai. She is also the managing trustee of Children's Liver Foundation, actively working towards awareness, advocacy, and support of families affected by pediatric liver disorders. In addition to her clinical and academic work, Dr. Nagral is a TEDx speaker and a strong advocate for Wilson disease awareness. She has delivered over 500 lectures and has more than 100 publications. So we are very privileged to have the chance to learn from her experience today. Over to you, ma'am.
Thank you, Dr. Kshitija, and thank you, ORDI, for this invitation. I think it's a great work which ORDI has been doing to raise awareness and advocacy for patients of rare disorders. And I think, events like this are really going to be helpful for our patients, and I hope we're able to have a good interaction with the patients. I think without much delay, I'd like to share my slides. Are you able to see the slides?
Yes, ma'am.
Yeah. So I'll be basically talking about my journey with this disease, what I learned along the way, and I learned a lot from patients, as you'll see. So this was way back in the mid-90s when I just passed my gastroenterology degree from KEM Hospital in Mumbai. And KEM being a referral center for liver disorders, I was interested in liver disorders. And I got an opportunity on a scholarship to visit the Royal Free Hospital in the UK. Now, you must have heard about Dame Sheila Sherlock. This is the dame, and this is me way back in the 90s, who has this famous hepatology textbook, which everybody read when they wanted to read anything to do with liver disorders. And I had the opportunity to actually work with her. And she was the one who actually established the first dedicated liver center in the world at the Royal Free. So it was the first dedicated liver unit, so to say, in the world, which was separate from gastroenterology. At the Royal Free, my first exposure to rare diseases was attending a Gaucher disease clinic with Professor Pramod Mistry, who is now a world expert of Gaucher disorders. He's based out of Yale right now in the US, and he's done a lot of work in this disorder. Now, what I saw here in this clinic, so it was a clinic which was exclusively for patients of Gaucher disease. This is a disease I had heard of, just heard of. We did not think it existed in India at that time. And I could see patients of all ages, right from a 3-year-old to a 55-year-old with this disorder in that clinic, patients who had large splenohepatomegaly. And I realized that we were probably missing these patients in India. We were taught that these patients hardly are seen in India, and we really didn't even bother reading much about this disease because it was thought to be very rare and not existent. And what I realized when I came back was that it was not existent. Many of these large splenomegaly patients were being missed because they were thought to have tropical splenomegaly syndrome or a malarial spleen. And soon after that, we started tests for these patients and realized that this disease does exist in India, and we continue to work on this disease and try and getting them treatment. So this disease was a rare disease and was very much seen in India, but that was my first exposure way back in the 90s. After I came back from my fellowship abroad, I came back to KEM Hospital, and I got invited, in fact, to KEM Hospital to attend a support group meeting. Now, until then, I had never heard of a support group meeting. And so I was very curious to know what was this meeting. So this was held in the pediatric ward of KM Hospital, which is on the ground floor, ward number 1. And this is Professor Barjor Bharucha. He had set up a genetic clinic along with Dr. Kumta in the pediatric ward of KM Hospital. And this you can see is a side room here. And this is where we had the first support group meeting. So what was there in that meeting? There were these 7, 8 families of patients with Wilson's disease along with the patients, and Dr. Barjor Bharucha was at the helm of the table. And he, along with his residents, asked the patients to kind of narrate their histories, and was discussing with the patients about what their issues were, and what was it that they felt was lacking, and what was the diet which was supposed to be had in this disease. As you know, Wilson disease is a disease of copper metabolism where you have excess copper, which normally gets excreted through the body into the bile. But in patients of Wilson's disease, they are not able to do it. It's a genetic disorder, it's a rare disorder, but I think it's one of the commonest rare disorders that we see. And it is a very treatable disorder. And this is what he was trying to convey to his residents. I sat in a corner watching the proceedings. I saw how, over a period of time, these patients started, the families started slowly interacting with each other, exchanging notes, and learning from each other. And I realized that support group meetings were indeed a great way of offering kind of camaraderie with each other, and knowing that, this is a disease where you're not alone. So soon after that, there was a very first patient who was referred to me as Wilson's disease. This was a 13-year-old girl born of a non-consanguineous marriage. And she had been diagnosed as Wilson disease based on certain tests, but she was not responding to the standard treatment, which is D-penicillamine, for more than 6 months, which is very unusual because Wilson's is a very treatable disorder. And usually over 6 months, one does get an idea whether the patient is responding or not. She had presented with jaundice at the age of 11 years. Her liver tests were abnormal, as you can see, and her albumin was low, INR was high, suggesting there was a chronic liver disease. Her ceruloplasmin was on the borderline. Her urine copper was above 100, which is abnormal. She had the so-called Kayser-Fleischer rings or KF rings, which we always see in the eyes. And on ultrasound, there was cirrhosis. She, in fact, got a liver biopsy done, and it showed a high liver copper. Now, the interesting thing was that though she had so many points which suggested Wilson's, her age in the first place, her urine copper was high, her KF rings were positive, she had a high liver copper, she was not responding. But the clue was that her liver biopsy was not showing changes of Wilson's. In fact, there are no specific changes of Wilson's, but whatever that are there, you can see fat, or you can sometimes see Mallory's hyaline in Wilson's, none of which was there, but there was evidence of what we call cholestasis. So this was one clue that this may not be Wilson's disease. Uh, so we went on to do her genetic test and it did not show any mutations. Of course, majority of patients today will show mutations on the genetic test, but there are a small number who may still not show mutations. She went on to get later, after many years, getting a whole exome sequencing done. At that time, we only did the ATP7B because that was all that was available. And then it turned out that she had a type of condition called PFIC3. So this was the first patient referred as Wilson's, but was not Wilson's, to highlight the point that there can be many tests which mimic Wilson disease, like a high liver copper, like the presence of KF rings, but that does not mean that there is Wilson's. And therefore, Wilson's needs, if you don't have the genetic test, which now is much more easily available, is much cheaper than what it used to be. Unless you have a genetic test available, you can't go by other tests to diagnose Wilson disease. Just give me a minute. So I started getting referrals for pediatric liver disorders. And at that time, I realized that pediatric liver disorders were not really anybody's baby. Nobody was really treating them. The adult hepatologists like me would try and treat them. The only lady at that time was Dr. Saroj Parekh at Wadia Hospital, who was treating some of these patients. And her major interest was in a condition called Indian childhood cirrhosis. Now, this is a condition which mimics Wilson disease and which we don't even see now, but there was some link to copper with that disease at that time. So we decided, and this was really kind of in a way pushed by us, that we should have something which will create awareness amongst doctors, amongst the general population, patients and their families about liver disorders in children, because they were a totally different spectrum. And one could not extrapolate adult problems to children, and these were much more complex, there were much more genetic disorders. So that led to the founding of the Children's Liver Foundation way back in 2011. By some of these are parents of patients and some of us are doctors here. So they were trustees of this foundation from different walks of life. And over the years, there were a lot of meetings, like support group meetings, which were being conducted, and there were many meetings which were conducted for pediatricians to educate them and interact with them on various problems which children may encounter and make them aware of some of these problems, like Wilson's, like biliary atresia, which can be picked up early and treated potentially. So we had several such meetings for doctors. This is our website, and we have a lot of stuff here for patients, for doctors, and we also have regular journal updates which are put month on month, depending on for the doctors on what is latest in published in pediatric hepatology, so to say. So our foundation over the years was mainly focusing on awareness. Now we also help children financially, and there are certain other advocacy initiatives which we have taken, which I'll talk about. So I was attached to Kasturba Hospital. This is incidentally known as the jaundice hospital of the city, and all patients of jaundice, whatever be the cause, get referred here. What we realized was there were many young individuals who got admitted with prolonged jaundice, who would not have any virus positive, who had no drug history to suggest the cause of jaundice. And I started wondering whether these were patients of Wilson's disease, because that's one of the way in which patients present in the young age and prolonged jaundice. What we realized was that we would send them to Nair Hospital, and many of them for the presence of KF rings, to see if they had Wilson's. And many of them would come back saying that the KF rings were positive. It did, and almost 80% of the patients who had prolonged jaundice came back as KF rings positive, and we realized that they were not really KF rings, because when the jaundice disappeared and they were sent back, the KF rings had so-called disappeared. Now we will know that KF rings persist over so many years, and that too after they have been treated. Here patients were not treated as Wilson's, but just that when the jaundice went down, their KF rings disappeared. So we learned an important lesson, and we published this, that KF rings actually can be mimicked by what we call bile pigment rings, which are seen in patients with deep jaundice. They are in different layers of the cornea, and very good expertise is needed to diagnose KF rings. Otherwise, they will get misdiagnosed, especially in those who have deep jaundice. So this was one learning for us. And this is what this diagram shows. This is how the slit lamp examination looks. This is the slit lamp examination for KF rings. And this is a patient with KF rings. This is a patient with bile pigment rings. These are the different layers of the cornea in which you can see this is where the KF ring is and this is where the bile pigment ring is. So yes, so one has to be very cautious, and one has to have a very experienced ophthalmologist to look at the KF rings, because often the diagnosis is based on the presence of this ring, as was in that patient which was sent to me the first time. So over the years, as I said, we had several support group meetings, and what we realized was certain interesting things, like Wilson's patients could not write very well. They had major handwriting changes. In fact, change in handwriting is one of the first manifestations of neuropsychiatric Wilson's, but they could, over a period of time, draw and paint very well. And in fact, we would ask them, we had drawing competitions for them in these support group meetings. We asked them to display their paintings, and that's where they shared their experiences. And overall, the thought process when they meet, when the families met and voiced their concern, was that they are not alone in all this. And it was really useful in boosting up their morale. The support group meetings over the years grew in a big way. So from 2019 to 2023, we've had several meetings, and the number of patients also grew. In fact, it was the old patients who would then tell the younger ones or the new ones as to what their experiences were. And when patients talk to patients, they are much more convincing than we doctors talking to patients. And that's how I think the value of support group meetings has really been ingrained in my mind. And I think they're a great way to convince patients about compliance with drugs, about being regular with follow-ups, and also about what is it that concerns them, with a free interaction with the experts during these meetings. This was another learning lesson for me from a patient. Now you can see on the left panel, the yellow, you can hardly make out what this patient has written. And this is what happened to his handwriting. He was a person who would take notes in the court. And he said, my handwriting cannot be read anymore. And those days, they were not typing on computers, they were handwriting. And after, he had hepatic and neuro Wilson's, and this was an adult who presented with Wilson's. You can have Wilson's anywhere from the age of 3 to 55 presenting clinically. Now, as he got treated, his handwriting became quite legible, and we could hear, or we could rather read clearly what he had written. But after a few years, I had advised him high protein supplements so that his liver status got better. And he came back after a couple of years saying that his handwriting had become great. But after I had prescribed him a protein supplement, his handwriting had again deteriorated. And I was initially very reluctant to accept his theory that it had started after he took a protein supplement. But yes, I started thinking. And when he got me the protein supplement, I realized that I had given him a soya containing protein supplement. And we know that soya is very high in protein, in copper. Though it's high in protein, it's also high in copper. And this is what he was not supposed to have. So he was actually right. And this is another lesson I learned, that always listen to the patient, because you learn from the patient. And sure enough, after this soya supplement was stopped, his handwriting came back to normal. And then we went back to look at what are the various types of soy proteins which are available in the market. So we realized that you have, one sec, let me close this. So you have the soy flour, which has the maximum amount of protein, 4 milligram per 100 grams. And then in descending order, you have soy nuggets with soybean oil having hardly any copper. Soy milk is a little above that. So the ones at the end are okay to give because they have lesser copper compared to soy flour, soy nuggets, etc. So again, in soy, there's not one fixed kind of product which can be given or cannot be given. Each soy product has a different amount of protein, and one should generally avoid soy flour and soy nuggets. So that was another learning experience for me. This was a boy, a young 8-year-old boy who had come with a hepatic Wilson's, and his major problem was swelling in the knees, as you can see. Now, this swelling was attributed to D-penicillamine, which is the first drug of choice which we give to patients of Wilson's. However, we changed. We stopped the D-penicillamine, we changed to trientine, and in those days, trientine was not even available in India. But we gave him thinking that it was the D-penicillamine which was causing this joint swelling, but his swelling did not subside. And his liver status also was deteriorating. He underwent a liver transplant, and the moment he was transplanted, within a few weeks, his joint swelling completely disappeared. So we learned that Wilson's disease itself can cause swelling of the joints, and it is something which we don't see commonly, but one needs to be aware of that. Also, when we as liver specialists look at patients who have cirrhosis, we go by what is called the MELD score, Model for End-Stage Liver Disease, and in children it is Pediatric Model for End-Stage Liver Disease, MELD and PELD scores. But we realize that in Wilson's patients, we cannot apply these scores. And just because a patient has developed ascites or has developed other complications of cirrhosis does not mean that they necessarily need a transplant. This was a boy who was sent to us for a liver transplant. You can see he has a fluid in his belly, a lot of ascites. And we said, let us give him a trial of drugs. And after 2 years later, you can see he's been completely normal, regained all his weight, and doing very well with no symptoms. So there are separate scores which one needs to apply for patients of Wilson's disease when it comes to deciding on whether they need a liver transplant or not. These are New Wilson's Index and ARC scores which we use, and one cannot extrapolate the regular scores in them. And even in the presence of ascites, jaundice, unless the patient is in encephalopathy, when the ammonia levels go up and affect the brain, that is a situation where they definitely often need a transplant. But other complications of cirrhosis, one can actually salvage them and avoid a transplant. We also learned that in the same family, you could have one patient, like one on the left who had neuropsychiatric Wilson's and one on the right had liver Wilson's. So it can happen in the same family, which means they had the same genetic mutations, but the manifestation was different in both of them. Both of them went on to have successful pregnancies with the kids shown here and are doing well. So this was another thing, that another learning point, that in the same family, one could have different phenotypes of Wilson's disease. And the other thing we found was that often the patients come back with symptoms, and typically in a patient who has been on treatment, done well, improved, again, if that patient deteriorates, the first thing which comes to our mind is whether they are taking their treatment properly or not. And because most of them are often adolescents, we find that in this age group, like any other adolescent, patients tend to stop treatment on their own. And when they stop and have recurrent symptoms, their phenotype, or the way, phenotype means the way they manifest, may actually change. So somebody who has a liver Wilson's and stops treatment may come back with neurological symptoms, and the other way around. Somebody with neuro Wilson's may come back with liver failure after having stopped treatment. So this was the other thing which we realized could happen, and one needs to be aware for that. And these are the kind of things we tell our patients during the support group meetings. This was a complication which we saw in patients who were on long-term penicillamine, and is something we need to watch for and stop penicillamine or reduce the dose when they have these complications. It's known as EPS, or elastosis perforans serpinginosa, which is a rash which is often seen over the neck due to long-term, many, many years, decades of intake of penicillamine. We also looked at quality of life, and we realized that those who had neuropsychiatric Wilson's had a much worse quality of life compared to those with a liver Wilson's, and especially in children and their families, quality of life was much worse, which actually got better as the duration of the disease increased, because they learned about the disease and their symptoms also got better. We even kind of designed a scale, what is known as the Global Assessment Scale, or the GAS, to have a holistic kind of assessment of the patient, which includes psychiatric manifestations, neuropsychiatric manifestations, liver manifestations, bone and muscular manifestations, and other symptoms which are seen in patients with Wilson's. It's not done routinely in clinical practice, but it is good to monitor patients if they have multiple symptoms to get an objective assessment of how they are doing. We slowly started getting patients from all over the country and also from abroad. This was a patient who, way back in 2015, got referred to us from Pakistan. And the patient's family had limited means. And in fact, surprisingly, the country actually opened up its purse strings, especially in Mumbai, where through the process of crowdfunding, we could mobilize money for her travel and treatment in India. She was completely bedridden with neuropsychiatric Wilson's, and this is last year where she is here. She's a writer and she's doing very well and writes so with complete normal cognition. This was the first time when we actually experienced crowdfunding, which is something which so regularly used nowadays. I mean, even a rare disease program depends on crowdfunding, so to say. So this was way back in 2015 when it was first used, and we realized that it is a useful means of raising funds for various patients. We also looked at the genetic mutations in our patients of Wilson's disease, and we came up with 6 novel mutations in our patients. With the commonest one was the C813 C replaced by A mutation, which we identified in our patients in about a quarter of our patients. Now, there were some two parents. We normally only look at children and their siblings. The other thing which we learned is that when you have a young child coming to you, the parents are also young. They are in their 30s, 20s, early 40s. It's worthwhile testing them also for the disease, which we were not doing earlier. But as a part of this study, we did it, and we realized it's a good idea because we picked up two asymptomatic, what we now refer to as pre-symptomatic parents, aged 32 and 34, who had no symptoms, but who were not just carriers, but had the Wilson disease. So it's a good idea to test parents as well when we are testing index case. So test parents and test the siblings. This was a nice paper which looked at mutations from all over the world. And interestingly, you can see that there are more than 900 mutations described today. When I was doing my residency at KEM, it was 300 mutations. So you realize that over the years, how more and more mutations get added to the database. But what you can see here is interesting, that no other country has north, south, east, west described. So we know that India is a very diverse country. So they have looked at mutations in India specifically from the various parts of India. And the 813 mutation is seen in south, east, and west, but not seen in the north, which has other mutations. So what was interesting was to see how mutations differed in different parts of the country. And again, reiterating the fact that India is very genetically diverse and different parts of the country are very different genetically, which was reflected in what we have seen in various studies from different parts of the country. So this was a 9-year-old girl, Rabana, who was referred to us actually when she had a liver kind of condition. She had mainly liver cirrhosis and its complications. She was referred to us for a transplant. In fact, we were preparing for a support group meeting when she came, and she was very fond of dancing, and she said, I would like to participate, though she was not really up to it. She couldn't come for the meeting because she got hospitalized before that, and soon within a couple of weeks, she succumbed. Her family was obviously quite shaken up, but we made sure that the family came to us, and three of her siblings came to us and they got tested. So we often, what I want to stress here is we often forget to test siblings and family members, especially if the patient dies and the patient is no longer there for follow-up. But please keep it in mind that even such patients call their families back, make sure that the families are tested. Three of her siblings got tested, all were asymptomatic. And fortunately or unfortunately, you can say all three got diagnosed with Wilson's, and today they are much grown up. This was way back in 2019. They are, in fact, they just visited me last week, and all three are doing well. So it's a very, very treatable disease, and all we need to do is pick it up on time so that it can be effectively treated. Sometimes the neuro-Wilson's patients can have very damaging disease, and though the typical findings are in the basal ganglia, sometimes they can have changes in the cortex of the brain, so to say. And this kind of Wilson's is very unlikely to recover neurologically, but this is a rare type of Wilson's. Just wanted to highlight this because now our Hepatology Society, the American Association for Study of Liver Disease, ASLD, says that some Wilson's patients can be transplanted if not only for hepatic Wilson's, but if they have a bad neuro-Wilson's. So this is should be taken with a word of caution because neuro-Wilson's, of course, can improve after liver transplant because the primary defect is in the liver. But the important thing is to check how bad or how severe is the liver disease. Because if somebody has changes like this, he or she is very unlikely to recover even with a liver transplant. And therefore, I thought it was important to highlight this. So, when we had so many patients coming to us, we had the opportunity of sharing our experiences through various publications on Wilson's disease, which we did. We even came up with guidelines, and this was the first time in the history of liver disease that guidelines included adults, pediatricians, liver specialists, both adult and pediatric, and also neurologists, because most of the guidelines which had been published from the West for Wilson's disease in the past had only included liver specialists. And we realized that it is a disease which is requiring a multidisciplinary approach. You can have a liver patient with neuro symptoms and the other way around, and both teams need to be kind of giving their opinions and managing such patients. So this was a combined multidisciplinary effort, and we came up with certain guidelines. And first of all, we said that Wilson's, besides genetic workup, of course, cannot be diagnosed by one single test. One has to have a list of tests, and we give it a score. And there was a score which we designed called the modified Leipzig score. So we talked about if the ceruloplasmin is a single digit value and if it's less than 5, then it's a very high chance. Any score of 4 or more would suggest Wilson's. We removed the test called penicillamine challenge because it did not really help in diagnosing Wilson's. We also removed liver copper as a diagnostic test from this score. When I was a resident, that was the gold standard, liver copper. But we know now that many other conditions, like the example I gave, can have a falsely high copper, especially if you have a cholestatic liver disorders, and therefore one could not go by liver copper to diagnose this condition. Family history of Wilson disease was a good thing, and that was added and got a point. And we also included brain MRI because there were classic changes of Wilson's seen. So it's easy to diagnose neuro Wilson's by the very specific clinical symptoms and the brain MRI changes, as again liver Wilson's, which can mimic many other disorders and is not so much easy to diagnose. So what happened? In 2016, most of our patients were on D-penicillamine, and suddenly this drug went out of the market. And we started investigating like detectives as to what was exactly wrong. At that time, Triantine was not made in India, not available, and patients were trying to get Triantine because D-penicillamine was not there. Triantine, which is the other chelating drug, was available only in the gray market. 1 month of therapy was costing more than 1 lakh. Not just that, it was available erratically. Sometimes it would be available, it would not be available. So we tried to find out as to what exactly had gone wrong. And we realized that because D-penicillamine was being used only by Wilson's being a rare disease was not used by too many patients, and therefore the pharma companies did not find it cost effective to make this drug in India. The active pharmacological ingredient, what is called the API, was actually being made in China, and to import it and make this drug was not proving cost effective. So that is when we, as Children's Liver Foundation, along with many other groups, kind of approached the government, filed RTIs to find out why this was not available. We also realized that many patients developed complications. Some of them had to go for transplant because the drug was not available. And this was one such complication which we found, which got reversed after the patient was restarted on D-penicillamine. So we tried to find out why was Triantine not available, because it was available in the West from the 1970s. This was in 2016. We did not have this drug called Triantine. And again, through investigation, we got to know that this drug, Triantine, had an API which was being made in Hyderabad in India and was being exported to other countries for making the drug, but we did not have it available in our own country, which was quite paradoxical. So, along with the government, we lobbied again, and we finally got Triantine to be made available and made in India. And the cost of this drug obviously was 1/10 of what it was when it was being imported from abroad, and that too in the gray market. So finally, we had this drug in 2019 coming into India and is now freely available. So we realized that through advocacy, it was possible lobbying with the government agencies, with the pharma companies to get these drugs available and at a much cheaper cost. The government also made it mandatory for D-penicillamine to be used, to be available and to be made for Wilson's patients, and no company could refuse making this drug. So we have today both these drugs available in the country. So what we have learned is that it is the most common rare disease. Wilson's disease is a great mimicker, as I showed you in the first patient, and continues to surprise us. Some of them have got diagnosed with MDR3 disease, which is PFIC3, because it closely mimics that disease. We should not miss screening family members, including parents. And it's not only prescribing drugs or giving them diets, they need holistic management. Counseling is extremely important, especially when it comes to rare disorders. It's support groups also are very effective. And doctors really do make the best patient advocates. And I would like to take an opportunity to thank all the patients who have taught me so much, and also thank patients who have granted permissions for me to share their pictures and stories. And before I end, I would like to involve and invite all to join our next Wilson disease support group meeting, which is happening on the 24th of January, which is this month at Karjat. The numbers are written here. You could take a picture, and please feel free to join us. Just that you need to register compulsorily, and we need to know that you are coming. Thank you very much.
Thank you so much, ma'am. This was a very engaging and enriching session, not only for the patients, but even for us clinicians and advocates who are there in this webinar. So it was very reassuring to show through the examples, the real life examples that you gave about patients whose outcome is dramatically changed with timely diagnosis and management. And even for us who are like clinicians who are familiar with the fundamentals of Wilson's, these nuances and these insights which you shared about PFIC mimicking, Wilson's, or say bile pigment rings being misinterpreted as KF rings, and even the cortical cystic necrosis was a very new thing to me. So it
Yes.
was very valuable for us also, ma'am.
Thank you.
Thank
Yeah.
you so much. So, ma'am, so I would just like to ask whether you have patients who are doing well on like long-term chelation, or do all of them need liver transplant?
In fact, as I said, majority, if they are picked up on time, except for a patient who comes to you with acute liver failure the very first time as in and is in encephalopathy, majority of the patients do not need a transplant. And many people apply the rules of cirrhosis to Wilson's also. A patient with ascites, decompensated cirrhosis, okay, go ahead with transplant. No, most of these patients we've been able to salvage without transplant. So I think Wilson disease and cirrhosis related to Wilson should be treated differently from other cirrhotic patients. And as I said, now people are talking of the brain indication for liver transplant. So transplanting those with neuropsychiatric Wilsons, but one has to be cautious. And I think this will be on a patient to patient basis that one needs to take that decision that this patient is not responding. And the patient cannot be so severely affected, being bedridden, etc. And then expect the transplant to do wonders. So it has to be a case to case basis. But yes, that also has become one of the indications for liver transplant.
Right, ma'am.
Yeah.
Uh, there are some questions in the Q&A section. I will read them out. Mr. Kannan is asking, is it possible to pick up in early stages through NBS? Is it possible to pick up Wilson disease through newborn screening?
Yeah, you can do the ATP7B peptide. There's a test called that, which has been talked about. It's not yet freely available, but it's one peptide which they are saying can be incorporated in the newborn screening, and one could actually pick it up early. You can pick up with the regular ATP7B NGS or whatever you call that at birth also. So once you know that somebody in the family, typically it is an older sib who's had a problem, the diagnosis can be made at birth also with this genetic testing. Though clinically, typically patients will not present before the age of 3. It's only after the age of 3 they come with symptoms. Liver patients tend to come earlier in the first decade, and neuro Wilsons tend to come a decade later, after second decade onwards.
Right, ma'am. And ma'am, is this disorder covered under this National Policy for Rare Diseases, the NPRD? Does it get
It
covered?
is covered, yes. It's one of the few disorders which can be, one could afford to completely, manage through the money
The-
which comes in. Many other rare disorders, the money is never enough. But this is one of, fortunately, not expensive to treat disorder, and therefore, and a very curable disorder. So this is one disorder we should not miss at all. Yeah.
Right, ma'am. Okay. So, are there, okay, so
No, no
any
other.
more questions are not there? Right, ma'am.
Okay.
So, ma'am, you would say like key differentials for Wilson would be like PFIC3 or some
Yeah,
other?
that is, there are many others like aceruloplasminemia, certain other cholestatic disorders can mimic Wilson. So any cholestatic disorder can give you KF rings, can give you high liver copper, can give you high urinary copper. So and therefore there's no one single test for diagnosis. Of course, genetic is separate, but there's no other single test for diagnosis, and therefore these scores come in. So yes, it can be a mimicker. So there's a nice article in the NEJM where you can look it up on the mimickers of Wilson's. I think there are some more questions there.
Yes, yes.
Mm.
So, Mr. Sanjay is asking, can neuro Wilsons recover?
Yes, most neuro. So the paradox about neuro Wilson's is that it gets diagnosed very easily because symptoms are very classic, as
Mhm.
against liver Wilson's, which can mimic many disorders. But neuro Wilson's takes much longer to recover. So, but neuro Wilson's is never acutely fatal, which liver Wilson's can be, because they can just suddenly come with an acute liver failure, which can be potentially fatal if not transplanted. So, yes, they can recover, but they take a longer time for recovery. So the last thing to recover, it depends on how severe the damage is. As I showed you that patient with frontal lobe, incorporation and damage. Such patients are not likely to recover completely. They will have neurodeficits which will persist. And the last thing in my experience which recovers in neuropilsins is the speech. And what I was saying, we need a multidisciplinary management. It's not only for hepatologists, for for geneticists, but it will also mean speech therapists, physiotherapists, dietitians. All these need to be treating the patient. And for neurovilsons especially, it's extremely important that they go through speech therapy, through physiotherapy, and these are often ignored. I find most patients just getting medications, but if there is good, and this is what we emphasize in our support group meetings, that they come for, they get regular speech therapy, they get good physiotherapy, and they do well. But it's requiring much more patience, managing these patients. And of course, the affordability also is an issue, but simple exercises done at home, like, need atta gundna, just what we call, it's a very good exercise for dystonia of your hands, which many of these patients have. Or, singing along karaoke on YouTube doesn't take much. Uh, the more you talk, we tell them, the better your speech is. We ask them to write one page every day. So they time their handwriting, they see how their handwriting is improved. They come with their notebooks to me. So I see how their handwriting is improved over the years, how much they are taking in terms of time to write each page. So these small things I think are also important, and not just drugs and diet. So yes, they can improve, but somebody who's come very late in the disease with contractures, bedridden, yes, it is a little challenging in those patients to completely improve. That's what I would say.
So next question is from Mr. Shakib. He asks, if any patient is diagnosed with Wilson disease, will he have neuro Wilson or liver Wilson or both? What
They
would be
can
the...
have either. That's what I showed. They can have liver Wilson's predominant. So it's always predominant. See, the disease starts in the liver. So most patients have livers affected, but the liver may not manifest with liver complications. So you may have a silent cirrhosis, and the patient manifests with neuro symptoms only. But if you investigate, you'll find LFTs are normal, liver function is normal, but on ultrasound there is cirrhosis. This is not uncommon at all, because the liver is the site where the problem starts. Other way around, when you see a liver Wilson's, which means a patient who has predominantly come with jaundice, ascites, complications of liver disease, they can, if you do their MRIs, you'll find copper in their brains. So it's one disease affecting liver, eyes, brain, but it may be just one system which is predominant and manifesting clinically. And as I said, what we observed was, if somebody has liver Wilson's and does well and then deteriorates because there is non-compliance, number one cause of deterioration is non-compliance. They stop taking drugs because they feel they are absolutely normal and I don't need to take any drugs. And this patient with neuro Wilson's, who has had neuro Wilson's earlier, now is coming with liver failure. He's never had any liver failure before, but because the liver is affected, the brain is affected. It's just that it is not manifesting. And there are some unfortunate ones who have both symptoms, like the handwriting guy I showed you. He came with variceal bleed, so it was liver cirrhosis and portal hypertension, and he had tremors, which was affecting his handwriting. So you could have both clinically manifested. You could have but usually it is one predominant manifestation. And don't forget, Neuro-Wilsons also have a lot of psychiatric manifestations. So it is, interestingly, the psychiatric manifestations are only seen with Neuro-Wilsons. We don't see them with the liver Wilsons. So therefore it's called neuropsychiatric Wilsons. And there are very varied manifestations, psychiatric manifestations in these patients. So we need to get a psychiatrist into the picture who understands Wilson's patients. So, they also need that part of management. So it's really a big multidisciplinary management.
Definitely. So Mr. Kannan is asking, does gut microbiome have anything to do with Wilson?
Uh, yeah, good question. I guess now everything is being linked to the gut microbiome. Finally, it is the copper in the diet which is getting into our system and blood and reaching the liver. So I guess the gut microbiome must be playing a role. I'm sure we'll be able to do something to the gut microbiome in the future, and be able to decide how much of the copper gets absorbed. Yeah. So I don't know the answer yet, but I guess in the future there will be some answer on this.
Mr. Mohammed is asking, why can ceruloplasmin be normal in some confirmed Wilson patients?
So there are, so exactly, that's a very good question. So we talk of ceruloplasmin. If it's ceruloplasmin is what we call an acute phase reactant. So whenever there is any inflammation in the body, especially inflammation of the liver, because this is a protein produced by the liver, whenever there's inflammation, these acute phase reactants go up. So whenever there's an inflammation of the liver, you can have a falsely high ceruloplasmin, which is to start with low, but with inflammation, it has gone up a little to the extent that it becomes normal. So a normal ceruloplasmin cannot rule out Wilson's. And sometimes when the liver is very fibrosed, as an extreme cirrhosis, liver is protein, like liver produces albumin. Similarly, liver produces ceruloplasmin. So when it is completely, synthetic function is completely lost, the ceruloplasmin is not being produced at all, which will make the ceruloplasmin go falsely low. So you can have false high, false low. And therefore, one single test is not reliable. And therefore, you need a score to diagnose Wilson's. Of course, genetic testing has made it much, much easier now. You just write one test and it gets done. But there are, of course, you'll know better than me that there are certain situations where your genetic test also may be negative.
And there
So,
is a VUS, and then we have
yes.
to rely on what is the actual
Yeah.
presentation and
And that's
only.
when we need help from people like you to come to the diagnosis. Yeah, because you can have, like even in our situation, almost 30% of our patients were negative for genetic mutation. And these were like proven Wilson's, doing well on therapy, etc. So genetic tests, if they are positive, absolutely pathogenic, yes. But if you have what is called, what you refer to as VUS, variants of uncertain significance, you don't know what it is. So
True.
so yes, you do need geneticists also to help diagnose these disorders. Yes.
We have a lot of questions coming in, and we'll try to cover as many as possible. So, Mr. Avinash is asking, if a neuro Wilson patient is not willing to take medicine, can we mix it in food?
Ah, see, the thing is, now what are the drugs which we give for Wilson's? We give penicillamine, we give trientine. It's either penicillamine or trientine. Typically, we don't give both. And zinc. These are the three. Zinc acts very slowly, so it is not the first drug of choice. It is usually used for maintenance. Now, or in pre-symptomatic Wilson's, where you don't have any symptoms, but it has been picked up because you've done genetic testing on the siblings. Now, all these drugs have to be given on empty stomach. If they are not given on an empty stomach, the efficacy goes down significantly. So I'm not saying that they will not act, but probably I can't give a proportion, but maybe what can be done in two tablets, you may have to take 4 or 5 tablets for the same effect, because it's interfering with the absorption of the drug if you're giving it with food. So always in Wilson's, we say it has to be given on empty stomach. No food for an hour before or 2 hours after the drug. So this is the first advice we give, that it has to be empty stomach when you give these drugs. So not willing to take, I think better to take a psychiatric opinion as to why there may be a neuropsychiatric Wilson's, which is making that patient not take the drug. So give them some, show to a psychiatrist, mix the psychiatric drugs in the food, get his mental status right, and convince him to take the drug, is what I would say. Yeah.
Right. Mr. Amit Sharma is asking, what is the difference between D-penicillamine and trientine hydrochloride, and which drug is better for Wilson disease?
Uh, Both are chelating drugs, which means that both are getting the excess copper out of the body through the urine. So in that sense, they have a similar action. Uh, Trientine, I personally, there are people who would use trientine as the first drug of choice, but it is about 10 times more expensive than D-penicillamine. And for patients who are, like, for example, on an average, it will be about 1,500 to 2,000 rupees a month on penicillamine. On trientine, it will be about 15 to 20,000 a month. So, and for patients who are on very long therapy, it is a significant difference. So that's one. One has to afford the trientine, and we always like to start. I personally like to start with D-penicillamine unless there are side effects, and one needs to monitor side effects. And one important side effect is excess copper in the urine, like a nephrotic syndrome, which one can see with penicillamine. When you have to switch to trientine, with somebody like that, you will not give penicillamine, or somebody develops a Steven Johnson, typical skin allergies, low counts, there's some absolute contraindications where side effects with penicillamine you would like to start trientine. But there's something called neurodeterioration which can occur, which means you start the drug and the neurological status actually becomes worse. And there's a misconcept that it does not happen with trientine. It happens with both. And one needs to know that.
Sure. Mr. Venkateswaran is asking, has any Wilson disease patient on chelation or zinc developed seizures?
Yeah, seizures is very much a complication of Wilson's, neuro-Wilson's. Though it's not common, a neuro-Wilson's patient can have seizures. They tend to have more severe neuro-Wilson's. So exactly what I was saying, it is not the drug which is causing the seizures. It is the neurological deterioration which has happened because of the drug when you started the drug. So what we typically do is somebody has had worsening of neuro symptoms like tremors or seizures or speech getting worse. We cut down the dose of the penicillamine or trientine and then very gradually build it up. So seizures is not because of the drug. Seizures is because there is a neurological deterioration from the disease because the drug has been given maybe at a higher dose. So we need to cut down the drug.
And he's also asking, at which level of Wilson disease do neurological symptoms occur?
No, it's not
Like,
a level. It's not a level. Sometimes some patient may just present with neuro symptoms. So as I said, we don't know how nature decides that this patient is going to get neuro symptoms and this patient is going to get liver symptoms, and this patient with liver symptoms is after some time going to get neuro symptoms. So it's something which we don't know. It's not early or late, that early is liver and late is neuro. What we have seen is typically liver patients manifest early in life, and they may have no patients may have no liver symptoms and manifest later in life with straight neuro symptoms. But that doesn't mean that neuro is a late manifestation of the disease and liver is an early manifestation. It means that uh, so late is when they come with advanced symptoms. Somebody comes to you who is bedridden, who's hardly able to speak, who's hardly able to swallow. Sometimes we need to do PIG. We do that. We do what we call gastrostomies to feed these patients. They are not able to swallow at all. So that is late neuro Wilson's. So it depends on what stage and what symptoms they come with, which will decide early or late.
and one anonymous listener was asking whether geographic location can influence the development of Wilson disease.
Yeah, there are certain countries where the prevalence of Wilson's disease is very high. So it has been described, but yes, one thing which you as a geneticist, I'm sure, will be counseling patients, that we say once we have it in the family, we always tell them that avoid any further marriages within the family, what we call consanguinity. We know certain communities in India where there is more consanguinity compared to the others. So avoid any marriage in general within the family is the general advice we give.
Right, ma'am. I think it has been a very nice and interactive discussion that we had. And I would like to inform the audience, if you have any further questions later, you can email to us and we'll get back to you after discussing with ma'am. And thank you so much, Aabha ma'am. It has been a very wonderful discussion, highly interesting. And thank you, audience, for your patient listening.
Thank you, Dr. Shilija. Thank you, Adi. Thank you.
Thank you, doctor. Really, it was good. The other, it's not a normal
Thank you.
theoretical CME. It
Yeah.
has a mix of everything, and it was addressed to all the people.
Yeah.
and very convincing, very easily understood. Thank you so
Thank you.
much. Yeah.
Thank you.
Thank you, Dr. Kshitija. Bye.
Thank you. Thank you so much.